Do you know that we define this as the presence of pain over the lateral epicondyle of the humerus during loading of the wrist extensor muscles? And it is common between 1 to 3% of the general population, generally at the middle ages. And there are some activities that increase risk, like smoking, doing manual work, or playing tennis. It is clear that this is a disbalance in the quality of regeneration of every tendon, and Dr. Teran was very clear talking about this. We know that the inflammation could appear at the beginning of the process or as a collateral situation related to the degeneration, but it is not the main problem. We know that there are changes that include vascular, chemical, and cellular degeneration, and this is the main reason for the chronic tendinopathies. In this case, they are located in the insertion of the extensors of the wrists and fingers, and the pathophysiology is related with several features. If we speak about genetics, there are some patients that have a tendency to have mesenchymal problems, and this is called mesenchymal syndrome. And generally, we see in those patients rotator cuff tears, epicondylopathies, carpal tunnel syndrome, and the Caven disease. It has been related with some types of blood, like zero. So we need to be aware of that. Some authors have even go forward and talk about the new integrative model of lateral epicondylalgia, in which the tendon itself, of course, is very important, and the changes that the tendon suffer, but there are changes in the pain system, in the way that patients are able to recognize and feel pain, and also in motor systems, like alterations of corticospinal control and the way that we move our upper limb. So it is not our classical point of view, but now when we speak about tennis elbow, we must also consider that it is a nervous system mediated phenomenon. It is related with physical functioning and even with psychological factors. For instance, it has been described that patients who suffer epicondylopathy have, for instance, a level of tolerance of cold that is lower than the average of the population. So the pain perception is different in these patients. You all know the tests that we use to recognize this pathology. And of course, there are images. Sometimes we can see calcifications in the area of the tendons, as we see here. But ultrasound is a very informative technique in which we could see a thickening of the extensor tendons, the presence of microcalcifications, ruptures that can be small, but in some other cases are big ruptures. And even with the Doppler effect, we can evaluate the alteration of the vascularization. MRI is also useful. We also see areas of inflammation in some cases, thickening of the tendon, and even the rupture, as I said before. We know that in many cases, ultrasound and MRI are showing changes that are not related with symptoms. And this is very common in this type of pathology. Some studies have evaluated the contralateral elbow and have seen the same changes in an elbow that is asymptomatic than in the symptomatic elbow. So, of course, we must always put the information bring by the images in a context and considering patient's symptoms. We have a long list of differential diagnoses, beginning with pain coming from the cervical spine, but we also know that patients with problems in their elbows have in average a higher level of neck pain than the general population. And perhaps this could be related to that lower threshold to refer pain or to feel pain. There are other situations that should be ruled out, like the presence of loose bodies, osteochondritis dissecans. That is very I have seen patients like this, and the symptoms are very similar to the ones of the lateral elbow. Plicas have been controversial for some authors. They have a very important role in the physiopathology of these symptoms, and for others, they are just something that we found and they are not related. But if we rule out all the other pathologies, all the other reasons for pain, and we treat conservatively the patient and we do not see response, perhaps it is important to go ahead with a resection of these plicas. Elbow posterolateral impingement is very common in throwing sports and should be considered. And we can also consider elbow instability. There is an association between shoulder pain in the area of the epicondyle and instability, because the lateral ligament is fused in some areas with the tendons, the proximal insertion of the extensor tendons. There is a very close anatomical relationship between these structures, and we must consider this. A very sometimes very difficult differential diagnosis is the radial tunnel syndrome. It is an entity that was even denied by some authors, and it is considered a compressive neuropathy of the posterior interosseous nerve. It is more common in ladies in the middle ages, and these patients refer a very important pain. EMGs are not completely clear about this pathology. It is more common in the dominant side, and in many cases there is a history of shoulder pathology, carpal tunnel, and Decker-Venn disease. Generally, the pain is aggravated during night, and many patients refer arm fatigue. The area in which the pain is localized is generally distal to the typical area of pain of the tennis elbow, and generally the tests cannot be very clear for this. It has been described this test in which the proximal forearm in its ventral aspect is divided in 9 different areas. Each area has the size of a $quarter coin, and it is considered that if the pain is located in the areas 1 and 2, it is a typical localization of pain related to the radial tunnel syndrome. In the blue areas, there is no relation, and in the areas 5 and 6 in yellow, generally the reason for pain is the compression of the proximal median nerve. There are some tests related to neurodynamic, that is an approach that is developing fast in the last years. And the maneuver to recognize pain coming from the compression of the posterior interosseous nerve is, as you see in this picture. The wrist should be put in flexion, in very extreme flexion, and hyperextension of the elbow. And in this position, we ask the patient to flex his neck, and generally there is an increase of the symptoms. In that case, it is considered that there is really a compression of the nerve. But as you see, is a very subjective and not completely exact procedure. MRIs can show indirectly some changes related to the compression, like edema of the nerves, of the muscles, but we have found that ultrasound of the posterior interosseous nerve is very useful. In this case, you can see comparing the normal side with the affected side, and as you see, the nerve in the area, in the side that is affected with the presence of symptoms, is almost 2 times the size of the nerve on the contralateral side. When we talk about the treatment of elbow pain, we must consider in these cases that prevention is very important, and to reduce repetitive load volume, improve musculoskeletal base, and improve sports skills, especially in those who play tennis. It is very important. The sport should be adapted to the patient and not the patient to the sport. And sometimes this generates problems and is difficult to deal with. It is important also to eliminate acquired risk factors, like, for instance, smoking. Some authors propose a wait and see policy because they consider that this is a self-limited disease, and rest and education should be useful. But the problem is that this way not always lead to a complete resolution, that up to a third of patients have prolonged discomfort, and there is a high recurrence rate, especially in those who practice sports. It is very difficult in our society, in our modern society, to make some people realize that they are not young anymore, and that the quality of their tissues is not the same as some years ago. And for some people, it's difficult to adapt, to get adapted to a new rhythm. But I think it's very important to talk about that. We know that some prognostic factors can give us an idea of what will happen in the future. For instance, if we have a tendon rupture, of course, the prognosis is not as good as if the tendon is in good condition. It is correlation between the severity of pain and disability and the prognosis. Central sensitization, like, for instance, as I said, lower threshold to pain in general will give us a worse prognosis. The presence of associated musculoskeletal comorbidities, as we said, perhaps the patient is not having just a problem in his shoulder, but also having some other problems, and making us think about a mesenchymal syndrome. Also associated neuromuscular impairments, patients who have a alteration of the corticospinal control will have a worse prognosis. And finally, as you all know, work-related problems and psychosocial factors will make our prognosis worse. Many different of treatments have been proposed for treating this condition, but the problem we have is that there is no conclusive evidence for any one of them, including surgery. The pharmacotherapy has conflicting evidence and secondary problems, and the corticosteroids, it was said, for instance, speaking about plantar fasciitis, also provides short-term relief, but not for a long time. Some authors have proposed the use of antidepressant or anti-epileptic drugs with good results, and these would work in those with central sensitization. Manual therapy has a moderate evidence in the literature. We all use stretching and strengthening of the muscles, and that's a very good indication. The use of braces, even though has not a very strong, a very solid scientific evidence, is very useful for many patients. So we use strap for epicondylopathy, and even we have seen that there are some techniques like taping that have been communicated as useful, but there is still not a strong evidence. PRP injections have been controversial, but it seems that related to shoulder pathology, to elbow, sorry, pathology, uh, some authors have good results and can be an option once non-invasive techniques have been ruled out. There were some other treatments like the use of nitric oxide, polydocanol injections, looking for sclerosing the aberrant vessels, but they are not frequently used. What about shock waves? Well, there are good results that have been published both for radial pressure waves and for focus waves, for extracorporeal focus waves. But they do not have the first level of evidence, a grade of recommendation A, as for instance, pathologies like calcifications of the rotator cuff or plantar fasciitis. They have a grade of recommendation B because they are papers communicating good results, but we do not have yet enough number of level of one or meta-analysis papers supporting this. Even though that this is a review that was published by Thiele in 2015, and they made an analysis of the evidence in the literature, and they saw that most of the papers having results that were not completely good were published till 2002. And after that, uh, related perhaps to the quality of the devices or the techniques, the results, the good results are more uniform. This is level 1 paper published in the Journal of Bone and Joint Surgery that shown the presence of good results and significant results with the use of shockwaves. This is another paper comparing shockwave, focused shockwave with percutaneous tenotomy in resistant tennis elbow, and the clinical results were similar after both procedures. Of course, if shock waves do not give good results, and we do not have good results, for instance, using PRP, surgery is the option. There are open techniques and arthroscopic techniques, the combination of both. This is the treatment algorithm that we propose. The first step is rest, rehab, the use of killers. We can use ice according to the patient reaction and the patient experience with it. Exercises and brace. If it doesn't work, the second option would be the use of radial pressure waves or focus shock waves plus exercises. Exercises are essential always. And if not, needling or the use of PRP. I am not sure if PRP is working because of its biological effect or because of needling. Uh, we know that there are some authors that are advocating that the prolotherapy is useful. So it would be interesting to discuss and compare that in some studies. And if it is not working with these techniques, the next step would be surgery. Fortunately, most of the patients have a good result with the first and the second step, and it's not common for us even to go to the third step. But we shouldn't put the patients in risk and use invasive methods if we have not completely considered the results of the non-invasive methods. Thank you very much. That